All right, hello everyone, and welcome back to our next installment in our clinician-performed ultrasound series. I am Joe Minardi, and I'm here to talk to you a little bit about ultrasound of the abdominal aorta. So, of course, disclosures, I don't have any. No drug reps sponsor me. I don't get any drug money. I've told you that before, I think. I'm going to start off today with a couple of cases that we'll introduce and then we'll come back to at the end. So our first case, this is a case that you might see if you're working in our emergency department, or maybe you're moonlighting, or they might come into your clinic and roll in, and family brings him in. It's a 68-year-old male. He was found to be kind of less responsive. Wife came in and found him, and he was kind of complaining of his back hurt. He's moaning, and when he shows up, his blood pressure is 74/35, and his heart rate is 43. So just start thinking about your differential and what you're going to do with that guy, and we'll come back to him. And then our next case is a gentleman who just comes in to a rural clinic. You know, someone suggested, hey, maybe you should see a doctor. You haven't really seen one in years. So he comes in. He's a 72-year-old man. He used to be a smoker. He did quit a few years back, and he's really here just to establish care. He doesn't really have any complaints. And like I said, he doesn't go to the doctor very often. His blood pressure is 164/112. And again, he doesn't take any medicines, doesn't go to the doctor. So think about him, especially in the context of the aorta. Would you care about it or not? And we'll talk about it. So our topic today, of course, is abdominal aortic aneurysm. Why do we care about it? It is a big cause of death, 13th leading cause in the United States. And most of the time, it doesn't hurt. People walk around with these things until they rupture, and then once they get symptoms, things go bad for them very quickly, and they often die, or sometimes have a slow, painful death in the ICU after you try to fix them, and it can lead to badness. And it's frequently misdiagnosed because symptoms can be nonspecific, or it can mimic other things. Often renal colic is one of the most common misdiagnoses of a ruptured aortic aneurysm. And so that's why we're going to talk about screening and maybe using ultrasound to help us make more rapid diagnoses when they do present with symptoms that may or may not be aortic aneurysm. So I like to always talk about the reasons to image, how to interpret, then how to integrate clinically. So first off, why would you take a look at someone's aorta? The first one, maybe it's just for screening, and we'll talk about who needs screened, maybe who doesn't. But then once they're symptomatic, the symptoms they may typically have are back or flank pain, sometimes abdominal pain. They might present just with syncope, and they may present in florid shock or cardiac arrest even. Or they may have embolic phenomenon, or you may hear an abdominal brewery or feel a mass on exam, and you want to use maybe ultrasound to get some better delineation of what's going on. So just to talk a little bit about screening, some of the biggest risk factors are being male. Like many cardiovascular diseases, being male makes you more risk, and that's certainly true for AAAs. Almost unheard of in patients under the age of 60 to 65, so increasing age, again, like many cardiovascular diseases. Smoking in the past or current smoking is a significant risk factor, and then family history is another risk factor. There are some other more obscure things, people with collagen vascular disease and things like that, but those are the most common big risk factors. And what the U.S. Preventive Services Task Force recommends is that any male aged 65 to 75 who's ever smoked should have at least a one-time screening for abdominal aortic aneurysm. And what Medicare, at least according to the most recent resources I could find, they pay for males who pretty much fit that bill, 65 to 75 who have ever smoked, to be screened for AAA, or anybody really with a family history. So these are probably the people to think about. These are the people you'll probably get paid for. Not that that's the only reason, but if you're screening asymptomatic people, these are kind of the guidelines to go by. The diagnoses you can make. Mainly we're looking to make the diagnosis of abdominal aortic aneurysm. You can make the diagnosis of dissection, but very important to note that dissection is not a diagnosis that can be excluded on the basis of ultrasound alone. It's not sensitive enough to exclude dissection. So you might make the diagnosis, but you can't really rule it out. So let's just talk a little bit about some of the data that's been out there. So in emergency department settings, it's been shown that if we do this ultrasound, and we've been found to be very accurate at nearly 100% sensitivity to diagnose it in symptomatic patients, and with this we're able to get patients diagnosed more quickly and get them to the operating room more quickly, and hopefully save some lives, decrease some of the morbidity associated with the diagnosis. And again, doesn't take a lot of training. This is a relatively straightforward, simple exam to do, and for symptomatic patients at least, the sensitivity by emergency docs is nearly 100%. But this has also been studied in family medicine clinics and family medicine practices, especially for screening, and it's been found that with, again, not a ton of training, family physicians can effectively screen for this in the office, and it takes them on average about 3.5 minutes. So, pretty good bang for your buck if you can do something this quickly, and you're right in the office rather than referring someone for an appointment or an ultrasound that they may or may not follow up to do. You just do it right then while they're there. And I think, again, I'm an emergency physician. I don't work in a rural practice clinic or a family medicine clinic, but in my mind, I think the perfect time to do this is if they're coming in for fasting lipids or glucose screening. You could add this right onto that screening visit, and you knock out some of that stuff right away. And so we often talk about with ultrasound questions, we're trying to mostly focus on kind of binary questions. And for this one, the question we're trying to answer is the aorta dilated, yes or no? And that's pretty much it. Just a little quick, very, very brief overview of the anatomy. The aorta sits in the abdomen. It's a retroperitoneal structure, and we're hoping to find it after it exits through the diaphragm, and we want to follow it all the way through the abdomen, all the way down until it bifurcates down at the iliac bifurcation. And you'll see the celiac trunk, you'll see the superior mesenteric artery, you might see the renal arteries, and then the inferior mesenteric artery. I hardly ever see that, but it certainly is there. As far as setting up, you're going to use, the transducer you're going to use is probably going to be a curvilinear, or if all you have is a phased array that looks something like this one over here, then you could use that. This is probably your transducer of choice if you have it, but you could use either one of these, something that's lower frequency, around 3 to 5 megahertz. Patients should be supine, and your preset is probably going to be a general abdominal preset. If you have something more specific like aorta, certainly use that, but usually it's going to be something like abdomen. And the technique, again, is really relatively simple, and for screening, really you just need transverse images. You don't really even need sagittal images to do a screening exam. You really only need sagittal images if you're trying to characterize pathology, but in the majority of patients who hopefully are normal, transverse images, as long as they're complete and you go all the way from the xiphoid to the bifurcation, that's going to be adequate. It is important to make sure you get all the way from the xiphoid all the way to the bifurcation, somewhere usually around the level of the umbilicus. And nicely, the aorta usually sits right in the middle of their abdomen. It's relatively consistent. It can be a little tortuous sometimes, but it's right there. It's an important point. You'll notice the way that this operator is holding the probe. It's very straight up and down, and that's one of the tips I'll give you for imaging the aorta, is that you want to be straight up and down on top of it. If you do a lot of fanning off to different angles, you're going to lose it pretty quickly in some of the bowel gas. So you want to stay nice and vertical right on top of it, and you usually have to, really push that transducer down into the patient's abdomen. Even of thin folks, if they've got much bowel gas or anything, you really need to get some pressure down onto that abdomen. And so you'll have them, inhale, exhale, and warn them that I'm going to push on you for a second. And just to recognize what it's going to look like, so these are all transverse images. So patient's right is here, left is here, this is anterior, this is posterior. And what I'm going to try to get you to do, the first thing to look for is the vertebral body. And I think I have a little, so yeah, find the vertebral body. That's going to be the first landmark to look for, then find your aorta. And so right there, there's our vertebral body. You see it makes an arch and a shadow. That's a pattern to look for. That's vertebral body with shadow behind it. And then right on top, on the patient's slightly to their left, usually is going to be their aorta. And if you stare at it for a second, you should see it pulse. You'll often see the inferior vena cava over here a little bit more to the patient's right. Sometimes if you're pushing pretty firmly, you might collapse it, may not even see it that well. But look for the vertebral body, and then the aorta should come into your view pretty quickly. And our other example here, again, there's our vertebral body, the anterior arch. You see the characteristic shadowing behind, and then we've got our aorta right there. So I'll just pop those off of there again. Practice finding that vertebral body and then looking for the aorta. We got some more practice coming. All right, just a couple more examples again, and most of these examples are from my practice or practice of my colleagues in the emergency department, so none of these patients are fasting. If you do this on a fasting patient, your images are probably going to look a little bit prettier. So you maybe have an advantage over me, but again, look for that vertebral body, characteristic, shadowing behind, and then the vertebral body should pop up right on top, or the aorta should pop up right on top. There we go again. You getting this? There's a pattern. Vertebral body, there's the aorta, and again, you watch it pulse as you sit there. And here we've got a few live images, and you'll notice this is just the changes that occur as the patient breathes in and out. You can see how being patient during inhale and exhale, you can get a little prettier view during the exhale, and as they inhale, it's not as pretty, but you see that vertebral body, shadow behind, and then there's the aorta. And same thing over here. We see vertebral body, shadow, and then there's the pulsatile aorta, and you can see the central venous pulsations of the more flat, more almond-shaped inferior vena cava over here on the patient's right. And if you take a look at the aorta in a long axis or a sagittal plane, you'll see that it gets more superficial as it courses distally. So this is a sagittal plane. Patient's head is here, feet are here. This is anterior, this is posterior. It's deeper as it goes into the chest, and as it courses towards their feet, it gets more superficial. This is all spine back here. It also tapers a little bit as it goes distally, so that's important to note. As you're following the aorta down, it should never get bigger as you're working your way towards their feet. If it gets bigger, then that's likely an aneurysm, even if it's still relatively small. And the diameter to keep in mind is 2.5 centimeters. The abdominal aorta should be 2.5 centimeters at its widest diameter, and if it's much wider than that, then that's most likely an aneurysm. A couple more little clips showing you some of the anatomy. Some anatomy that you may see depending on if your patient's fasting or thin, or if you just get really pretty images. So what we've got over here we can see, here's our vertebral body. You see that arch, the shadow, and our aorta is right here. And what we're seeing here is the celiac trunk. It comes off, and you see this seagull. And that's the seagull sign. That's the celiac trunk. That's the first vessel. And then right below it, they're very close. Over here we see, again, here's our vertebral body, shadow, here's our aorta, and right on top is almost like a small bullseye on top is the superior mesenteric artery. And sometimes that can be mistaken for the aorta, but usually it's too small, it's more superficial, and it's not right close to the vertebral body, so that's how you cannot mistake it for the aorta. And here's just a longitudinal view again. Head is up here, feet are here. This is anterior, this is posterior. This is our aorta coursing towards the feet. And I think I've got some labels here showing you how close these really are. Celiac trunk goes off and splits right and left, and then the superior mesenteric artery comes off and then courses distally and pretty much follows the aorta, stares right at you in a transverse image. And sometimes you might get really lucky, again, depending on how nice of images you get, and you might see renal artery. So here's the right renal artery over here. And then on this image over here, we can see the left. This is superior mesenteric. and IVC's over here. This is our left renal artery. A lot of times you aren't going to see these, and it's not incredibly important to see these if you're screening or just if you're asking yourself the question, is the aorta dilated or not? You don't need to see any of the branches to answer that question. But if you see them, it's nice to kind of know what the anatomy you're looking at is. And again, I just want to point out you want to image all the way down to the bifurcation. Usually the bifurcation is somewhere around the level of the umbilicus, and so make sure you're all the way down there and look for the bifurcation, and it's almost sometimes referred to as like a double barrel, like a shotgun. So there we've seen bifurcation, and you want to see all the way down to there. And again, just note vertebral body, bright white, shadow. Again, over here we've got vertebral body, bright white, shadow. Here's our double barrel. Here's IVC. It hasn't split yet. And so some of the pathology, what you might see. So these are aneurysms, and really what you can see is they're big. And the nice thing is large fluid-filled structures become more easy to identify by ultrasound because they propagate sound well. So here we see this is about a 3 centimeter aortic aneurysm. It's probably more like 4 centimeters in widest diameter transverse. You see you measure all the way past clot. You measure from the outer wall to the outer wall is where you measure these things. You don't measure within the mural thrombus. Here's another one. Again, we can see the vertebral body here, bright white, shadow, and this is a very large aortic aneurysm, and again we're measuring all the way out to the outer edges of those walls. A couple more examples. Again, we've got lots of thrombus within this aortic aneurysm, but we measure all the way out to the walls. This one, again, pretty large aortic aneurysm. Here again, vertebral body, shadow, and here this is a smaller one, but still an aortic aneurysm nonetheless. And here's a couple other examples of pathology that you might see. Again, you can't rule this out, but you might see dissection. So here we've got a little flap going transversely in this case. Here we've got a more vertical flap in these aortas. And if you see these are patients that definitely need to have further workup, especially if you're seeing these people and they're symptomatic. If you're in the clinic, they probably need to go to the emergency department. And if you're in the emergency department, you've got a diagnosis and you've got to decide what to do with it right away. You probably want to get in touch with a vascular or a cardiothoracic surgeon depending on the extent of where this goes. We're not going to talk about thoracic or aortic root dissection at this point, but if you see this, you should be concerned and work this up expeditiously. Just some other things you might see. This is someone who's been grafted, so they have this very large aneurysm, and here you can see their grafts that have already split to their iliacs. And you might see these if you were screening someone because maybe they forgot to tell you about their graft. You would see this and be surprised, but you could figure out what it was and then ask the patient about it. So how does this help you in clinical decision making? Again, if you're in an emergency department setting or even a clinic setting, but someone comes in and they're symptomatic, you may be able to quickly make this diagnosis and get the patient to the right care, mobilize the right resources much more efficiently because you've made a diagnosis at the bedside immediately and can certainly direct your next steps in evaluation management. Call EMS, call for a helicopter, or get your vascular surgeons on board right away if need be. Can also narrow your differential. So say they come in and they've got flank or abdominal pain, and you can look and say, well, their aorta is normal, so it's probably not a ruptured AAA, and then you can narrow your differential and think, okay, do I still need to pursue dissection, or should I just go down the renal colic pathway or some other part of your differential that, again, you've narrowed a little bit because you've crossed the diagnosis off the list. And again, you can efficiently screen for these with a little bit of training, again, 3.5 minutes added on to your office visit. Just go through a couple of the tips. So you want their abdomen as soft as possible. So if they're having pain, hopefully you can treat their pain. All these things that I remember learning about physical exam way back in med school. Get their arms at their side, because that if their arms are up over their head, that tenses the abdominal muscles a little bit more. If you can get them to flex their knees a little bit, that'll help relax those abdominal muscles, and often having them take in a breath and then exhale. And as they exhale is often when that's when I'll push more pressure into their abdomen and get some of my best images, because that helps relax the abdomen. You want, again, stay vertical. You want to keep your transducer straight up and down. You don't want to do a lot of fanning. Sometimes you have to push pretty firmly on it, so just warn your patients. Say, bear with me a second. And sometimes you have to be patient, because sometimes you'll run into some bowel gas, and if you just give it a second, it'll peristalse through. Or sometimes as you compress and decompress, you can get it to work through and get out of your field. And then sometimes you can try some angles from the sides or fan slightly up and down to get around bowel gas, but mostly you want to stay vertical. Just a few other little pearls and things to keep in mind. Remember, it's difficult to diagnose a ruptured AAA by ultrasound, so I wouldn't routinely try to do that or think that you can, because it's difficult, because they usually rupture retroperitoneally, and that's much more difficult to image by ultrasound. So you got to use the whole clinical picture. And remember, you can't exclude dissection by ultrasound. You might rule it in, but you can't rule it out. So if dissection is big on your list and you don't see it on ultrasound, then you've got to do something more. You're not done. Very important to make sure you image the entire abdominal aorta. Usually we'll recommend storing at least an image with measurements from the proximal, the mid, and the distal aorta, and then show the bifurcation as well. But most importantly is, as you're imaging it, just find it around the xiphoid process and follow it all the way down to you see bifurcation. Small aneurysms do rupture. They're much less likely to rupture if they're small, but if the clinical picture fits and they have a small aneurysm, you should consider that that's the problem until you've ruled it out. So let's get back into our cases. So remember, our first case was the 68-year-old guy who was not feeling well, not as responsive, kind of moaning in pain, hypotensive, but not tachycardic, which actually is common with AAAs that are ruptured. And so this was his image. He had a very large aortic aneurysm. Again, rupture specifically was not diagnosed, but the clinical picture fit. He has a large aneurysm, so that's the assumption. And the resuscitation was able to be focused quickly, and a vascular surgery consult was able to be made while the patient was still at the bedside, and patient got good care. And it was much more expeditious. And then our other case, remember the guy, he was an older guy who used to smoke, didn't really go to the doctor, but someone finally talked him into going in and getting checked out. He is hypertensive, so we went ahead, and he was fasting. He'd come in, he was fasting for his lipids and glucose. We go ahead and take a look at his aorta, and he's got, it's asymptomatic now, but he does have a 3.5 by 4-ish centimeter aneurysm, and so we're able to give him even extra incentive to take his blood pressure medicines and control his blood pressure. And he was referred for a CT to further delineate the extent of his aneurysm and see vascular surgery and have very close interval follow-up and hopefully get repaired before he ruptures and his morbidity and mortality goes up dramatically. So here's a couple of the references. Some of the family practice stuff specifically came from a Canadian family physician article. And if you haven't seen it before, checked it out, I recommend you check out sonoguide.com. All kinds of great ultrasound education information. There's a ton more areas, but a lot of good info there and a lot of good practical stuff that you can take a look at. And then just, to summarize some of the key points, ultrasound of the aorta is pretty quick. It's pretty easy, and with not a ton of training, you can get pretty accurate at diagnosing abdominal aortic aneurysm. And again, we can rapidly diagnose or exclude a ruptured AAA and focus our management. And then for screening, which is recommended in certain parts of the population, it can be done pretty efficiently. And my goal and what I see is making this very useful in a rural setting so patients can get it done right there without having to go somewhere else and schedule another visit for another study. You can do it right there in the office. So that's pretty much what I got for you. I hope that was useful, and I look forward to hopefully seeing you in the lab and doing some scanning with you. Thanks.